Good morning, everybody. So my name is Lauren Weber. I'm one of the general cardiologists here, and I was asked to give you guys a walkthrough through the basic management of heart failure. As all of us are being tapped to potentially cross-cover on the wards or in the ICU, we're certainly going to see heart failure patients, so I thought this was a great idea to go through some of the heart failure basics. So this is how we're going to break it down. So we're just going to talk about some basic terminology that I want you guys to know when you're talking about a heart failure patient. And then I broke it down into ward care, and then I'm going to generally cover a little bit of ICU care. We're not going to dive too deep into the management of cardiogenic shock. That's really its own talk in and of itself. So certainly in the era of COVID-19, we've seen that there's a lot of overlap between COVID patients and heart failure patients, and it sometimes can be very difficult to kind of figure out which is which, and so hopefully you'll feel a little bit more empowered to be able to manage these patients on the wards. So some basic terminology. So generally we lump heart failure patients into two categories based on their left ventricular systolic function, so what the squeeze of their heart is doing. You either have heart failure reduced ejection fraction, which means your LVEF is less than or equal to 40%, or you have heart failure preserved ejection fraction, which means your ejection fraction is greater than 50%. And then there's this like gray zone in the middle here, but don't worry about that too much. Like for the most part, we treat these patients like HFpEF. The other terms that you will see used very commonly are ischemic versus non-ischemic cardiomyopathy. And that really gets to the etiology, what's the underlying cause of the heart failure. You can have any ejection fraction you want and have ischemic or non-ischemic cardiomyopathy. What's really important is that since heart failure is the most common cause for hospitalization in patients over the age of 65, we're really going to press you to try to figure out why. And if patients come to you and they have known ischemic cardiomyopathy, I want you to keep your antenna out for ischemia being potentially one of the reasons why they showed up to the hospital in heart failure. The ejection fraction, like what does that mean to you in terms of like how we frame them? So two things, like one is how we treat them. So we have specific therapies for patients with reduced ejection fraction that are going to decrease their mortality. And I'm going to show you and tell you how to manage those therapies when they're in the hospital. And then the other one is fluid sensitivity. So any patient who has heart failure is sensitive to fluid, but the patients with a reduced ejection fraction can be very sensitive and get into a lot of trouble if they get a lot of fluid up front, which is certainly something we need to pay attention to when patients are showing up acutely ill with more of a sepsis or a URI type picture. They may inadvertently end up getting a lot of fluids and then developing heart failure down the road. So I mentioned therapeutics. So the big difference between HFpEF and HFrEF is the types of medications that we have them on in terms of like the intent. So for preserved ejection fraction patients, it's very easy. We basically treat their hypertension and we give them diuretics, however it is that it works. For HFrEF patients, you can expect they're going to be on beta blockers, either an ACE inhibitor, an ARB, and a neprilysin inhibitor, which is relatively new to the market. There's only one, it's called Entresto. It's a combination of sacubitril, which is the neprilysin inhibitor, and valsartan. An aldosterone receptor antagonist, there's either spironolactone or eplerenone, and then a hydralazine plus or minus a nitrate, or plus I should say a short-acting nitrate. These medications decrease mortality, and that's really important because these are the medications that we want and expect patients to show up to the hospital on, and these are the medications we need to continue to manage while they're in the hospital, and then of course their diuretic therapy. So in terms of these medications, again, no matter how we get there, the whole idea is to keep patients like from avoiding volume overload or to keep them in compensated heart failure. And the problem with decompensated heart failure is that it looks a lot like an upper respiratory infection. And so in the era of COVID, what we've already seen in our institution is that it's sometimes very confusing, and patients will get admitted to the cardiology service, and what they actually ended up having was COVID-19 or COVID-19 and a combination of heart failure. So I've kind of split up the categories of symptoms into sort of two groups. So there's the ones that I expect that patients with a bad viral upper respiratory infection can have, and then the ones that for me sort of are hallmarks of volume overload. So COVID-19 or any URI patient can have cough, they're going to have shortness of breath, dyspnea and exertion, and although orthopnea, so the inability to fly flat, or paroxysmal nocturnal dyspnea, PND, waking up in the middle of the night short of breath should be heart failure symptoms, I find that patients with bad lung disease also complain of those two things. What they shouldn't have, unless they have heart failure, is weight gain, lower extremity edema, elevated jugular venous pressure, cool extremities, and early satiety. Those last two being markers of right heart function. I wanted to kind of give special mention to our historical clues. So we used to use chest x-ray, natriuretipeptides and troponins to kind of help us tease those things out in terms of like whether somebody had a cardiac problem or an upper respiratory infection. And what we're finding is that these are less useful in the COVID era, just because COVID-19 infection is going to give you abnormalities in all of these things. What I will say though is that you still can draw them, you just have to be careful in terms of how you interpret them. Troponin especially has been shown to be prognostic really in all disease states, and that's true for COVID patients as well. So the higher your troponin level, in COVID infection, the more likely you are to succumb to your disease. Some of the other labs that I do think might be helpful are lactate just generally as a sign of perfusion, and then total bilirubin or LFTs as a sign of right heart function. So that's heart failure basics. So let's switch to ward management. So when it comes to ward management, I've kind of grouped this into the do's and the do not. So when it comes to the do, I do want you to continue their chronic therapy. Now, early on in the COVID epidemic, people were worried that ACE inhibitors and ARBs seemed to upregulate the ACE2 receptor, and that seemed to be the entry point for the COVID-19 virus. So there was this theoretical risk that maybe the patients on those medications were going to become infected easier, and that has really not borne out in real life. So the Heart Failure Society of America, the ACC and the AHA have all come out and saying, please continue these medications because we do know that they reduce mortality in heart failure with reduced ejection fraction and are actually very important in helping us manage patients with HFpEF as well. So when would you hold the ACE inhibitor? So you're going to hold the ACE, the ARB, or the ARNI for AKI. And then you're going to hold the aldosterone receptor antagonist if the creatinine goes above 2 in women or greater than 2.5 in men, or if the potassium is greater than 5.5. The other medications you can continue as long as you have blood pressure room. So other do's. Please do double their outpatient diuretic dose. So you have 3 diuretic options for the most part. You have furosemide or Lasix, torsemide, and then bumetanide or Bumex. And it's important to know the equivalent doses. So 40 milligrams of Lasix or furosemide is equivalent to 20 milligrams of torsemide and 1 milligram of bumetanide. And then to convert Lasix oral to IV, you just have it. So 40 milligrams of oral furosemide is equal to 20 milligrams of IV. There is no IV formulation of torsemide in the United States that is available for adults. And then Bumex is actually just a 1-to-1 conversion. So to keep it easy, if your patient comes in on 40 milligrams of oral Lasix, just give them the same dose of IV and you've doubled the dose. Once you get to more than 120 milligrams of furosemide, I tend to switch over to these other 2 medications. Usually my choice is Bumex just because it comes in IV, but you could certainly use torsemide, and they have just better bioavailability and higher potency at this dose range. What are your goals? So if you have the right dose of diuretic, you should get urine output within 30 minutes of the diuretic delivery. And then you're going to titrate to either 70 to 90 cc's of urine per hour, or a goal of negative 1.5 to 2 liters net negative over the 24 hours that you're diuresing. Other do's. So please check electrolytes. At least daily. I usually will do twice a day for the first 24 or 48 hours while I'm trying to figure out like how patients are going to respond, but it all depends on how briskly they're diuresing. Also check daily weights. Now I know it's easy to kind of get hung up on this, but don't mind the like little bit of up and down. You're really looking for the trajectory over the course of the hospital stay. And then the last thing I will say will be to consider thiazide diuretics. So thiazide diuretics are going to be used in patients who have a little bit more established heart failure, who are coming in on higher doses of oral diuretics at home. And what would sort of prompt you to think about this is the patient who's responding to diuresis, but they just don't have a very robust response. So they're urinating within 30 minutes, but they're only getting a little bit. You can think about adding on a thiazide diuretic, and you've got really two choices that you will use more commonly. So IV chlorthalidone or diuryl, or oral metolazone. The dose for chlorthalidone is about 500, and metolazone is about 2.5 to 5 milligrams. You want to give your thiazide diuretic 30 minutes prior to your loop diuretic, and that's going to get you sequential nephron blockade. So the kidney, when it doesn't see a lot of perfusion either because of renal vascular hypertension or poor cardiac output, behaves exactly the same way as if it were dry, and it tries to hold on to salt. And in patients who are on chronic diuretic therapy, the kidney has gotten smart, and so is trying to reabsorb all of the sodium that it can through the distal convoluted tubule. And so by giving a thiazide diuretic, you're blocking that as well and enhancing your diuresis. These are, this therapy is very effective. It's not used for chronic therapy, and really patients shouldn't be discharged on thiazide diuretics unless you're in consultation with a cardiologist. You are going to see more electrolyte abnormalities when you add on a thiazide diuretic, so please be cautious of that. What I would say is after a couple of doses, once patients get going and they're urinating better, you can go ahead and DC the thiazide diuretic and just use the loop diuretic. Okay. So that's our do's. For our do not. So do not either initiate or increase beta blockers when somebody's in acute decompensated heart failure. It increases their risk of developing cardiogenic shock, and you can actually hurt the patient. So it's okay for them to stay on a beta blocker if they come in on a beta blocker, but you shouldn't increase the dose and you shouldn't start it off the bat. Please do not trend daily BMPs. It fluctuates too often to sort of really tell the trajectory. I think it's perfectly fine to check one once you're done and the patient's dry before discharge, or if there's been a very big change in their clinical status, but by and large this isn't going to be that helpful to you. And then the last one that I have is do not ignore hypertension. So high blood pressure is generally a long-term problem, but if patients are admitted for heart failure is one of the big driving factors for volume overload, especially in our HFpEF patients. So you can be diuresing them for days, but if they're sitting around with a systolic blood pressure of 160, you may not get that far. So afterload reduction is part of heart failure management. You might have noticed that I didn't put volume restriction, and I'm going to put that here under the you can if you want to, and you don't necessarily have to. It definitely makes the numbers look prettier in terms of your net negative losses for the day. Whether or not it actually helps you, my jury is out. So I think you can if you feel like it helps, but you don't necessarily have to fluid restrict your patients. Questions about any of that? All right. So let's talk generally about MICU care then. So you're taking care of a patient with heart failure, you're either first evaluating them or they're on your wards. What kinds of things are going to trigger you to say, hey, this patient needs ICU level care? And so really what you're looking for is signs and symptoms of low perfusion. So either cold extremities, hypotension, worsening labs, so their creatinine is going up, their lactate is going up, and their bilirubin is going up, T-billy. Or you're giving them all the appropriate diuretics and doses, but it's just not working. So these are the harbingers of cardiogenic shock. And so in those cases, those are appropriate patients for the ICU. Now, for us, if you ask a cardiologist what we do next for any of this, like our answer is usually going to be to do a right heart cath or to float a swan. In the era of COVID-19, where we're trying to avoid being in the room for a prolonged period of time with these patients and doing invasive procedures to them, I would say, you want to use your other markers, certainly these things which we've already used, in combination with your point of care ultrasound. So what things are you looking for on point of care ultrasound? I think for me, there's three big things. So what is the left ventricular ejection fraction? What does the RV look like? And what does the IVC look like? Understanding that if you have an intubated patient, the IVC might be dilated. If this all looks okay, you're probably still in the realm of distributive or septic shock and can continue to treat that. If this is abnormal, you may need to go ahead and do the swan or do the right heart cath anyway so that you can get some general numbers to help guide your therapy. So very generally, because it gets complicated quickly, and I promised you not a long talk on cardiogenic shock, when you're doing your right heart cath or your swan, there's a couple of numbers you're looking for. So your RA pressure, your pulmonary capillary wedge pressure, your cardiac index, and your stomach vascular resistance. And so for distributive or septic shock versus cardiogenic shock. So for distributive shock, your right atrial pressure should be low, as should your wedge. Ideally, your cardiac index is going to be high, and your SVR is going to be low. At least that's what we were all taught. In cardiogenic shock, your right atrial pressure is going to be high, your wedge is going to be high, your cardiac index is going to be low, and your SVR can be kind of anything that it wants to be. Our normal values for this are a right atrial pressure of 3 to 5 millimeters of mercury, a pulmonary capillary wedge pressure of less than 12, and a cardiac index of greater than 2.5. So for our purposes, we're going to think of cardiogenic shock as a cardiac index of less than 2.2 plus our signs of end organ damage. So really, we're seeing a lot of mixed shock so far in the COVID population, where they certainly have shock due to severe illness, and part of that is cardiogenic shock with low cardiac index. And in that case, you're going to be looking for inotropic therapy, plus minus continued diuresis, depending on what their wedge is. So my friend and colleague, Dr. Bunin, gave a great talk on vasoactive agents. I highly recommend it, and I can come back and talk to you guys a little bit more about the management of cardiogenic shock if you would like. But once you've gotten to this stage, and at any point along the game, you're really just going to want to call your friendly neighborhood cardiologist for us to come help you.